My name is Solrún. I'm just the workshop coordinator, and we're going to have four fantastic speakers with us today. They will speak for 20 minutes each, and then we'll have plenty of time for questions at the end. So please use the Slido like we did this morning. And maybe it would be good if you have questions for a specific speaker, that just say maybe number 1, number 2, number 3, or something like that, or use their names if you want to. Or it can be an open question, up to you. But first of all, I would like to introduce Ástþóra Kristjánsdóttir and Cecilia Guðmundsdóttir, who will be telling us about the Icelandic Home Visiting System. So the home visits for midwives in the first days after childbirth. And Ástþóra is a nurse and midwife specialist at the Department Center for Primary Healthcare in Iceland. And Cecilia is a pediatric nurse practitioner and the director of Well Childcare at the Development Center for Primary Healthcare as well, so services from birth to school age. And they are both experts in their field, so I'm looking forward to hearing what they have to say. Welcome. Thank you.
Thank you. Hello, I'm Ástþóra. Nice to be here and nice to see how many you are here. I would like to tell you something about our Midwifery Home Visiting System. Midwives are offering home visits. Just a minute. Okay. Midwives are offering home visits and they are working as contractors for healthcare centers and adhere to their own guidelines, which were issued by the Directorate of Health in 2014. The midwifery service home visits started in 1994, and we midwives are very proud of it. I think it's a very good service. There is around 80% of all mothers that use the home midwifery service. And that tells us, of course, that we must be doing something right. The service is not part of actual well childcare, but it is aligned with it, and often the same midwife caring for the family and the prenatal care offers home visits after birth, so there is continuity in it. Emphasis is on ensuring continuity and building trust with the family. Midwives determine the number of home visits based on individual need and the length of time the mother and baby stayed in hospital after the child was born. Usually it's 1 to 7 visits for the first 10 days. I made a plan which this is what we recommend. We divide the women in categories. Most women can choose to go home after, it's in the contract, it is 72 hours, but it is more likely that the primiparas goes within 24 hours and the multiparas go within 12 hours, if everything is okay. But of course, if they have a cesarean, or if they have lots of bleeding, or the child has been sick, or something like that, then they can stay a little longer and can be for 72 hours and get the service as well. So there is a lot, and as I said, 80% of the women get home visits. And there is always, but they have to be healthy women and healthy child, but we often have to watch out for many things, of course. The A group is for a normal delivery and 38 to 42 weeks. And if there is a multipara, then she can have 5 visits after delivery, but the primipara gets up to 6 visits. So there is we can change a little after how things are going. And of course, if something goes wrong, then we can add more visits. In some part of the country, where women choose to stay longer in hospital, like in the smaller places around Iceland, they feel it's just almost like home and then they just want to be at the hospital. But if they do not get the service after this 36 hours. So the midwives, we offer support for breastfeeding, and we can refer the mother to a certified breastfeeding specialist if a major problem such as mastitis issues with latching or sucking, sore, cracked or painful nipples, which we can't take care of, then we can refer them to the specialist. Okay, and each mother can get 3 home visits from the breastfeeding specialist in the first 6 months free of charge. Nurses in the well child care can also refer the mother to a breastfeeding specialist. And of course, all those 7 visits, 7 or 10 visits, 5 to 10 visits, they are all free of charge for the parents. What we are doing, the emphasis is placed on delivering the home visits is in an individualized way, meeting women and families with friendliness and respect, and of course at their home, where they feel at home. A focus is placed on the mother's physical and physiological well-being and the life changes that a new baby brings to the family. All infants are examined by the pediatrician 5 days after birth at the hospital, and a newborn hearing screening is done then. Prenatal care and home visits after birth is free of charge, as I said, for the legal residents of Iceland. And what are we doing in these visits? There is, of course, health education. We are talking about parent-infant attachment. We are talking about breastfeeding. We are talking about maternal well-being and the family communication. We are looking for all this. We are checking how the mother is physically and mentally. We are giving advice what to watch for, as the bleeding after birth, how are her breasts. We are checking the size of the uterus, the contractions, pain that the woman have, and of course, if cesarean, we're taking care of that. We are watching after signs from depressions, and we, of course, educate about normal blues after giving birth. Midwives, we assess the well-being of the family and ask and see how they are doing in their new role. Sometimes we are seeing some relations difficulties or attachment difficulties, and we talk about that. We look for the color of the baby, see how the baby is moving, checking the reflexes, how the color. We are taking blood tests from the baby if necessary. We are always taking the phenylketonuria blood test, and of course bilirubin if necessary. And we see and follow up to see how the breastfeeding is going day by day, and if the baby is taking the breast right and getting enough nourishment. Teaching the mothers what to look for with the baby's behavior, how parents can stimulate the baby, giving advice about parental skills, listening to the baby and learning to understand the behavior of the newborn. We are teaching the family how to clean and wash everything, and especially if the family is using bottles. We are teaching the family to give the baby a bath and take care of the umbilicus. We are talking about parent emotional skills, talking about and how it is necessary to get enough rest for yourself, food and sleep. And of course, if something, all is registered, and if something comes up, then we talk to the well-being, to the health clinic, and let them know, the nurses that will take over, will let them know if something is that we want to have a follow-up on. Yeah, okay.
All right. So I work in Well Child Care, and I work with Ástóra at the Development Center for Primary Health Care in Iceland. So when the midwives, they stop their home visits to the family, we take over in Well Child Care. But the aim of Well Child Care is to promote health, well-being, and development of children from birth until the age of 5. The service is located in general primary health care centers around the country. Nurses and general practitioners are the main professionals who manage Well Child Care along with pediatricians in some healthcare centers. Families usually see the same professionals in Well Child visits, and the emphasis is on ensuring continuity and building trust with the family. The service is free of charge as prenatal care and maternal home service, and all children are automatically registered into the system at birth. Families are not obliged to accept the service, but they all do. And they invite the nurses to their homes for home visits after birth. Some parents, they prefer to come to the clinic or to the healthcare center instead, but instead of the home visits, but that's not very common. The Development Center for Primary Health Care in Iceland leads quality development on a national level in collaboration with the Icelandic Directorate of Health and the institutions that provide primary health care in Iceland. The national guidelines are published by the Development Center of Primary Health Care in Iceland, and they are focused on evidence-based practices and built on previous domestic and international guidelines, such as the NICE guidelines. And they are revised very regularly. We also, procedures for implementation are nationally coordinated, and professional managers at each healthcare center are responsible for the implementation. At the Development Center for Primary Health Care in Iceland, we also offer training courses for new nurses in Well Child Care, and also for all professionals whenever new elements are added to the guidelines. Also, we have courses regarding breastfeeding, nourishment, nutrition, attachment, screening for anxiety and depression, etc. That is the same in prenatal care. There are also courses for professionals in prenatal care. And those courses are both online and on-site. And we need to have more courses, but as Ástóra, home visits in Iceland, home visits in Well Child Care has a long history in Iceland. Since 1994, as Ástóra told you about, the midwifery service visits family with newborn visits for the first 10 days after birth. The service changed in 1994, but that's when they started discharging mothers earlier from the hospital than before. That's why they changed the system. So when the midwifery service is over, we take over, and that's usually when the child is 1 or 2 weeks old. The first visit takes about an hour, and after that, 1 or 2 home visits are offered over the next few weeks, and more if needed. Nurses evaluate each case and decide how many visits are necessary. During these visits, the nurse examines the child's growth and development, discuss how to improve care, prevent problems, and provide support on how to take care of the child. Just as the midwives do in the midwifery home visits, we emphasize on delivering the home visits in an individual way, meeting the parents with friendliness and respect. Here you can see how the system is in Well Child Care. When the infant is 6 weeks old, the parents are invited to come to the clinic and meet a GP, and the nurse that was responsible for the home visits will receive them at the clinic. The nurse is in contact with the family during every visit, and the doctor is not present but is available if needed. We do health education every visit, and vaccination starts at 3 months. Standard information in Well Child Care is nationally coordinated through Haga, the electronic patient register. The Midwifery Home Service has not been using Haga as of now, but they will be doing that hopefully very soon, and that will improve the collaboration between these two services. The prenatal care uses Haga and well child care, so it will be great when the Midwifery Home Service will use that too. We try to provide the same quality of service everywhere in Iceland by making good national guidelines accessible for all professionals, measure the service through Haga, through data from Haga, and use the results to improve the quality of the service. Health information and educational materials for parents is on Heilsuvera, but Heilsuvera is a website and a web portal run by the Directorate of Health, the primary care of the capital area, and also now Landspítali, the National Hospital of Iceland. Parents can access information about health on Heilsuvera. Unfortunately, it's only in Icelandic now, except for few videos that are on the website that are in other languages too. So that's something we need to improve. What we do in well child care, we offer support for breastfeeding, and as Austra told you, we can refer to a specialist if there's a major problem that we can't help the mother with. We assess growth and development and counsel the parents about that, about parenting skills, accident prevention, and also the nurse monitors the development of emotional attachment between mother and child, and according to the guidelines. And this is done by observing the interaction between mother and child and the response of the child. If there's a problem that we can't solve, then we can refer the family to a specialist. During the first home visit, the nurse gets information about the family circumstances and social difficulties. And when indicated, mapping of the family relations and social resources should be drawn up through a genome map of the internal family structure and an eco-map of the relationship between the family and community. And also, if there's a problem that we can't help the family with, then we can refer the family to a specialist. We screen for depression and anxiety, but the mental well-being of the new mother is a particular focus in both prenatal and well child care. And so we've developed a standardized procedure for screening. And during the first home visit in well child care, we asked 2 questions about depression, woolly questions, and 2 questions about anxiety. And if the answers to these 2 questions indicate a problem, then we administer the Edinburgh Postnatal Depression Scale and General Anxiety Disorder 7, that means there are 7 questions. Then we administer that in full. Also, all mothers are screened in prenatal care at 16 weeks and also during the 9-week visit in well child care. Time is up, we can just slowly, What can we do to improve the service? There's a lot we can do.
Yeah, there's a lot we can do, and there is always this strong emphasis to improve collaboration between parental care and midwifery service, well child care and social services. And we are working on that, and we had a legislation that came through this year. Was it this year? Yeah. Which helps us to get things better. We always have to do better supporting mothers with their mental health being. Prevention, maybe that should be number 1. To teach mothers to take care of themselves, to teach people to take care of themselves, and we have used CBT, cognitive behavioral therapy, a lot in pregnancy, and that has shown good results for the women that are not very sick. So we will keep on doing that. But we have only done it for Icelandic talking mother, so we have to try to do it for in other languages as well. And of course, there is always the partner, which we haven't been, we of course talk to him and let him, he is with us all the time, but we could do more there. So, thank you.
Thank you very much. Thank you.
Thank you so much, Ástóra and Cecilia. And I see we have some questions. We will address them in the panel at the end. But next up, I am happy to introduce to you Eva Evrenius, who will be giving a presentation on parent groups in the Swedish prenatal and child health services. Eva is an analyst and advisor in parental support at the Swedish Family Law and Parental Support Authority. And for more than 15 years, she has worked with parental support and child public health, both as a strategic and as a researcher. Welcome, Eva.
Thank you, everyone, and thanks for inviting me to this nice conference. Through my lecture today, I hope to be able to give you an overview of parental support in Sweden, especially group-based such one, and during the first child's 1,000 days. And we have a long history of this, more than 50 years in Sweden. However, I will put more emphasis on the present than on the history. I hope to give you answers on why parental support has such an obvious place on the agenda in Sweden today. And I also hope to give you the answer on the question how it is designed. I will start to give you a brief introduction to our authority. And it's called Family Law and Parental Support Authority. In Sweden it's called Myndigheten för familjerätt och föräldraskapsstöd. It's quite a complicated name, and it's shortened MFOF. We're a government authority with, under the Ministry of Health and Social Affairs that works to ensure that children have a good and safe upbringing and good relationships with their parents. We are located in Skellefteå, in the northern part of Sweden, in the region of Västerbotten, and as part of the government's ambition to relocate national authorities. We are a small authority, although we are growing very fast. We're about 35 employees. And our previous government wanted to concentrate family issues to one special authority in a new authority in 2016. And in addition to this, MFO took over the responsibility for from the Public Health Agency for parental support a few years later. So here you can see our areas of focus, and we are a national expert public authority responsible for family law, family counseling, parental support, and we also work to ensure that the international adoptions to Sweden take place in a legal and ethical acceptable manner. Our main task is to gather and make available the latest knowledge and for decision makers and professionals, with families and children as the final target group. In all our activities, we should promote the rights of the child as they are expressed in the Convention of the Rights of the Child. We have a national strategy for parental support since 2018, and we have just written the final report, although it has at the same time been extended until the end of this year. And the goal is that all parents should be offered parental support through the child's entire upbringing, which means from pregnancy up to the age of 18 years. And the parental support should be performed within ordinary health care and other services, like you know all about, maternal health care, child health services, pre-open schools, open schools, and social services, but also those in the civil sector, like adult education and others. We have 3 prevention categories, and I think you are almost know all about it as well. The focus of the strategy is on universal preventive strategy, but also include targeted support for parents whose children belong to risk groups or have pronounced problems. In parental support, we also put a lot of focus, of course, on reducing risk and strengthening the children's and parents' protection. And we have, the government prioritized 3 target areas within the national strategy. And there's, the first one is a knowledge-based approach, the second is readily available support, and the third, a supportive and well-functioning organization. And in addition to these 3, the government also highlighted 3 perspectives that should prevail all work with parental support: the rights of the child, the gender equality and equal parenting, and equality in health. And our assignments are connected with national strategies, programs, and laws, as you can see here in the picture, where MFO has been leading the work with parental support for the past 4 years. We have the Convention of the Rights of the Child, which is a law in Sweden since 2020. We have a new mental health prevention strategy coming next year. We have programs on alcohol and drug prevention. We have the Agenda 2030, a lot of laws and regulations, and new one coming all the time. We have the national public health goals, and the first out of 8 public health goals is the condition of early life. We have programs on prevention, violence and crime, and the national strategy, of course, that I mentioned. And the healthcare system we have, of course, but also the county administrative board in Sweden called Länsstyrelsen, which also has responsibility to implement the national strategy of parental support and facilitate and cooperate with regional and local operators in parental support. And we also have a number of universities that have parental support on the research agenda. So already today we talked a lot about all the challenges to implement parental support everywhere for everyone. And I'm not going to go through this once again, but instead I would like to say that reaching out is one of the challenges, and there must be at least an offer to all from Society for Parental Support during a child's upbringing. We know that if we offer parental support for everyone, we have a greater chance of reaching parents who are in need of additional supports in an earlier stage. We have a definition according to the National Strategy of Parental Support, and it's parental support includes interventions and activities that have parents as the target group. It aims to strengthen parental ability and the relationship between parent and child. And parental support in groups may involve increasing parents' awareness of the child's rights, health and development of the child, and strengthening the parents' relationships in the couple with each other or within their social network. We have a new guideline coming in Sweden and will be published in the autumn from the National Board of Health and Welfare, Socialstyrelsen in Swedish. And the name is in Swedish, the translation is something like this: pregnancy, childbirth and the time after. National guideline for continuity in the care chain and care at the right level. Of course, individual meetings on repeated occasions will be the expectant parents are the basis for maternal health care's parental support. And this is supplemented with groups, in small groups, especially universal ones, but there are targeted groups as well as collaboration with other professionals and activities that are important for the family. According to the new guideline, the recommendation is that the health service should offer pregnant women and their partners or co-parents parental support in small groups together with other expectant parents, and that the health service should offer the midwives who are to lead parenting support groups basic education, supervision, and further training in leading the groups. This is not finalized yet, but you will see in the autumn what it looks like then, the final version. And then when the child is born, we have the Rikshandboken in Sweden, the National Handbook for Child Health Services, that is expected to reduce the need to develop local guidelines and recommendations and routines, and to assure the effective use of resources and equality in health. And the handbook aims to contribute to equitable and high-quality child health services by providing quality-assured guidelines to the professionals in all Swedish counties or regions. And here is a map of all themes of different meetings. Unfortunately, it's in Swedish, and includes also the aim and the goal of the parental support groups, how to prepare the group, how to lead the groups, and different themes. There is also a method support for digital parent groups. So now we come to the question, why, again? We know there are a lot of benefits of parental support groups. Expectant parents' ability and awareness of their own resources to handle a child is improved, making the transition after pregnancy and childbirth easier. A positive impact on parental mental health, support and promote breastfeeding, greater satisfaction in relationships with both partner and child. Parents' social network with other parents are strengthened, and children's externalizing behavior decreases. However, the evidence levels varies between these benefits. When it comes to health economic evaluations, health economic analysis of parental support programs used in Sweden could be obtained for a relative low cost. It started with the left report. You can see it's in Swedish. If you translate it, it's parental support isn't worth the money. It's from 2015, and for most programs, the municipalities' implementation costs were very low, and the municipalities gained on average twice as much as they paid within 2 years. And the later report from 2021 from RISE, the Social and Health Impact Center, was written in collaboration with two experienced researchers, came to the same conclusion: profitability for the early parent support programs. And the results of these two reports are strengthened by a recently published systematic review of economic evaluation. And in this review, parental interventions show good value for the money, in particular for preventing child externalizing and internalizing behaviors. So back to the question, how? We have gathered all the information on our website, mfof.si, so-called föräldraskapsstöd in Swedish, parenting support, which is marked in the box, in order to build sustainable support based on the national strategy for strengthening parental support. We believe it's necessary to structure and organize the implementation of parental support, both locally and regionally. And to facilitate this work, we have developed a method based on 7 steps that makes it easier to do the right thing. A clear overview of parental support programs and methods, and a checklist for supportive organization. And this website also has a video showing you how to get started, and in Swedish. At the moment, right now, we have a new assignment. Swedish municipalities have received 200 million Swedish extra crowns each year, this year 100 million, to increase support for families and especially parents. That is why we currently have a campaign called 2 Keys in 2 minutes, 200 million Swedish crowns, where we inform how the money can be used based on the national strategy. We also have the task of following on whether and how the money has contributed to increased parental support. And to translate this into euros, it's about €1 per person in Sweden this year and €2 next year. I'm not going to show you a film today, but you can look at this movie when you come home or later in the afternoon. And this is a good description of parental support in Sweden. And I would like to say a few words of this film. It's made in the county of Västmanland, and a very good example of a county administrative board promoting parental support according to the national strategy. Cultural parenting programs could play an important role in helping immigrants to adapt to their host countries, and parental support in groups usually offered to all first-time mothers in Sweden and their parents, but also to all immigrants who are expecting or having children since before. Here we have 2 examples. The first one is from Information Sweden. It's an information website about parenting rights and responsibilities. And the other one is from BRIS, the Children's Right in Society, about groups called Parenting in Sweden. So there is much work to do, and here are some of the recommendations for action in the report, The First 1,000 Days. I have chosen 3 of the recommendations during pregnancy belonging to parental support. And the first workshop was about promoting good mental health and well-being of pregnant women and maternal health care. And one of the first recommendation I want to pronounce is to develop a national web-based knowledge resource for health and social care professionals on how to run parent groups about equal parenting. And that's already going on from the slides I showed you before, so that's very good. And the second one is to generate knowledge about and increase the use of family centers as a place for intersectoral collaboration. And the third I've chosen is give midwives in maternal healthcare centers access to training and further training in how to run parent groups on equal parenting. The second workshop was about promoting good parent-child relationship in infant and child health care. And here I have also chosen 3 of the recommendations. Develop a national program for universal parenting groups with specific focus on improving parent-child relationships, which also includes skill training for health and social care professionals. Increase the number and regularity of training programs in how to run parent groups for all staff. And the third one, make permanent extended home visiting programs in the initial period after childbirth and focus home visits on breastfeeding, the early parent-child relation, and involving both parents. So, thank you very much for listening.
Thank you, Eva, very much. Next, we have Thea Sundrahagen, who unfortunately couldn't join us in person today due to, I think it was strikes and so on. But she is presenting to us from Norway, I think, Mamma Mia, an evidence-based online program for mental health promotion. And Thea, you are a doctoral research fellow at the Center for Child and Adolescent Mental Health East and South in Norway, and your PhD project is centering on the effectiveness on Mamma Mia. Am I correct?
That's correct.
Thank you so much, Thea. I'll let you introduce yourself more properly. Thank you.
Hello, and thank you. Oh, I have some feedback on the. Sorry. Hello, can you hear me properly? Du skruvar på ledningen så du hör om det hör mig. Kan inte skruva.
Hi, we can hear you.
Hello?
Yes?
Hello? Okay, good. Very sorry about that. All right, so thank you for the introduction and the invitation to talk here today. I'm very sorry I couldn't be there in person due to a flight cancellation. Today, I will present Mamma Mia, and this is an internet-based self-help program for universal prevention of perinatal depression and promotion of subjective well-being in the perinatal phase. So I'll take you through why and how Mamma Mia was developed, as well as previous and ongoing research. So Mamma Mia was developed by ChangeTech in cooperation with us and financed by Norwegian Women's Public Health Association. ChangeTech has also developed an app version of the program, which is being tested in the present study. And since last year, the app has been distributed by the Norwegian Directorate of Health as well. So why was Mamma Mia developed? The time in a woman's life when she's expecting a child is marked by a period of transition, which entails both role and identity changes. A lot of questions may surface, such as, will I be able to give this child what it needs? Who will I be as a mother? And who do I have to lean on for support? This enhanced sensitivity can be regarded as a preparation for the attachment that is soon to develop between the mother and her child. But it also makes her more vulnerable than usual. For some, this vulnerability may develop into depressive symptoms. It may, however, be difficult for women to know whether what they're experiencing exceeds typical experiences in the perinatal phase. For this and other reasons, such as stigma or lack of systematic screening in some places, a lot of these women aren't identified and treated. Having been depressed in the postnatal period may result in feelings of shame and guilt, as well as grief over having lost important time and milestones. And there are also consequences of leaving a perinatal depressive episode untreated for the respective partners, not to mention the children concerned. Furthermore, we know from research that a lot of those who suffer from postnatal depression already show symptoms in pregnancy. And therefore, both universal prevention, early detection, and intervention is absolutely key. And considering the fact that pregnant women and new mothers are some of the most active users of the internet, and internet-based programs seemed like the perfect fit. So Mamma Mia is an example of evidence-based practice. It's the product of an elaborate process where international research on both risk and protective factors in pregnancy and the postnatal period has been reviewed. Experienced public health nurses, midwives, and psychologists have been consulted, and pregnant women and new mothers themselves have been interviewed about their experiences and needs, as well as their user experience with Mamma Mia and suggestions for improvements after the program was first piloted. Mamma Mia is a self-help program for all pregnant women and new mothers, which delivers psychoeducation and evidence-based methods to influence factors that research has proven to be important for the 3 aims of the program, which are to promote subjective well-being, prevent perinatal depression, and also reduce, and to increase perceived social support. So the program begins in gestation week 21 with a total of 44 sessions, 16 in pregnancy and 28 after birth. And each session takes about 10 to 15 minutes to complete. The program content is adapted to where a woman is in the perinatal phase and consists of 3 separate digital rooms targeting different risk and protective factors. First, there's the mother's own room. How is she doing in the midst of everything? How can she get the necessary respite and take care of herself? The content is intended to enhance self-efficacy and promote emotion regulation through adapted psychoeducation about the perinatal phase. So to normalize and, very importantly, validate the woman's experiences. And through exercises, techniques, and assignments from positive psychotherapy, metacognitive therapy, mindfulness, and behavioral activation. The Edinburgh Postnatal Depression Scale is administered 7 times throughout the program in the mother's own room. The intended effect of this is manyfold. It's to increase emotional awareness, to provide an immediate help, and to increase social support utilization and encourage help-seeking behaviors. Women with scores indicating moderate to severe symptoms receive tailored metacognitive therapy and are encouraged to contact their doctor, psychologist, or seek out other professional help. Women with milder symptoms also receive tailored material and are encouraged to seek support from their partner or others in their social support system. This is then followed up when the woman returns to her subsequent session in the program. Notably, the tailored feedback is nuanced, so it encourages the woman to take into consideration any contextual factors, such as circumstances or events that may explain or contribute to an elevation of scores. So who is this little person? What is the baby trying to say? And how can I connect? The content in the baby room is intended to positively influence attachment and the parent-child interaction through psychoeducation about fetal and infant development, as well as exercises, techniques, and assignments from newborn behavioral observation and circle of security, which I know a lot of you are familiar with. We know this is important because understanding the baby's signals can enhance attachment as well as parental self-efficacy, and in turn promote well-being and mental health. Social support is of course important for mental health and well-being in general, but it's particularly essential in the perinatal phase. We also know that having a baby has the potential to change or affect the partner relationship. The parent room is about taking care of and supporting each other in this transition. So the content is intended to enhance perceived social support and also strengthen relationship satisfaction through techniques and assignments from Gottman's method, the prevention and relationship enhancement program, and elements from nonviolent communication as well. Users who register as not having a partner get the social room instead of the parent room. And here the focus is on strengthening other relationships with family or friends and how to obtain positive support from these relationships. And users who register as having a female partner get the parent room as well, but some adjustments that are mainly lingual. I will now go on to tell you about previous and ongoing research on Mamma Mia. So the first randomized controlled trial compared Mamma Mia as a self-help program to treatment as usual at Well Baby clinics. First, we looked at the effect of Mamma Mia on depressive symptoms on the Edinburgh Postnatal Depressive Scale. And as you can see on this figure, the two groups had equivalent average scores at baseline. And while both groups improved over the course of the trial, the Mamma Mia group had significantly lower scores as early as gestation week 37, an effect that remained stable at 6 months postpartum. And the effect may seem modest when displayed like this, so it's important to keep in mind that this is a universal prevention effort aimed at all pregnant women and new mothers, also those who are doing really well, which typically can make it difficult to detect a significant effect. And we can also look at the data in a different manner to better illustrate how Mamma Mia makes a difference. So here you can see the proportion of women who score above the cutoff on the Edinburgh Postnatal Depressive Scale at each point of measurement throughout the trial. And the light gray bars represent the Mamma Mia group. So combined, there's a 21 to 26% greater reduction in the proportion of women likely to have perinatal depression throughout the trial in the Mamma Mia group compared to the control group, which is arguably also clinically significant. Importantly, there's some uncertainty around these findings as we had higher attrition rates or dropout among women with elevated scores early in pregnancy and women with lower education levels. As this is a universal program, it's also important to evaluate effectiveness in terms of promotion of subjective well-being. We measured this with the positive and negative affect scale. For positive affect, there was a ceiling effect, so the scores at baseline were so high that there was no room for significant improvement. For negative affect, we found similar patterns as for the EPDS scores. The two groups had equivalent average scores at baseline. While both groups improved over the course of the trial, the Mamma Mia group had lower scores at gestation week 37, which remained stable at 6 months postpartum. We then interviewed 60 of the 1,300 participants from the first trial. We learned several important things. For instance, that for the women who dropped out, the interview in and of itself often led to them taking up the program again. We also learned that the women wanted Mamma Mia to be integrated in the Well Baby clinic. And they also wanted it to be offered as an app so it could be used anywhere and anytime. They also found the program to be a safe guide with information tailored to their needs, and that it enabled them to better utilize appointments with their general practitioner and the Well Baby clinic as well. So based on these interviews and also research on internet interventions, which show that the addition of guidance can reduce dropout and significantly increase the effectiveness as well, a guide for how this could be carried out with Mamma Mia was, as well as how it could be implemented at Well Baby clinics, was developed and piloted with promising results. In the current randomized controlled trial, we're comparing the effectiveness of Mamma Mia as a self-help program to Mamma Mia with guidance from the Wellbeing clinic. So clinics from all over the country are being randomized to either the blended care or self-help condition. We also want to look at whether this reduces dropout rates amongst women with higher or elevated scores early in pregnancy and lower education levels, as these are also probably the women at higher risk of developing perinatal depression. Furthermore, our partners at the Norwegian University of Science and Technology and the Regional Center for Digital Mental Health Services in Norway are contributing with a cost effectiveness analysis. And this will reveal the resource and economic consequences of implementing blended care for the participating municipalities and weigh these numbers against the relative effectiveness for the women and the potential benefits for the clinics and society. And this will give vital information about whether this form of guided Mamma Mia intervention should be implemented on a larger scale after conclusion of the trial. Right, so there are two primary aims of guided Mamma Mia. So the guidance they're providing the women at the Wellbeing clinic, and it's to explore women's experiences with Mamma Mia and facilitate use, which includes everything from basic technical support to validation of beneficial use and implementation of the content in the woman's daily life. And equally important is to use Mamma Mia as a door opener to address themes and topics that are important to her and related to her mental health and well-being. So all women in the experimental group, in the guided group, receive guidance from the Wellbeing clinic at 4 times throughout the perinatal period, integrated in existing consultations. So we have 2 with the midwife in station week 28 and 32, and then twice with their public health nurse 7 to 10 days after birth and 6 to 8 weeks after birth. The time spent on this in each consultation is meant to reflect the present needs of the individual woman, but should not exceed 20 minutes. And this is because previous research on guided internet interventions has failed to demonstrate a dose-response relationship or an increased effect beyond this cutoff. And midwives and public health nurses who participate in our study then receive both training and supervision over time on how to implement Mamma Mia in their consultations and in their Wellbeing clinic. While we are at an early stage of data collection, I can share some preliminary findings collected through training, supervision, and focus groups, interviews with the Wellbeing clinics. So one interesting feedback is that the midwives and public health nurses find it difficult to find the time to get to know the program in detail. And importantly, the guidance isn't meant to be a form of counseling where they are sort of the expert or provide concrete advice, but rather it's meant to be guided to a huge degree by the woman's initiative. And therefore, they don't actually need to know the program in detail. And we now see that this kind of transition or shift in mindset between some of the other things they're meant to do in the consultations can require some practice. They also say that Mamma Mia complements existing practice and that the supervision supports them in the implementation process. And in general, the feedback has been very positive thus far, and we're very excited to follow the clinics and the women throughout this trial and to see whether the addition of guidance will increase the already significant effect of Mamma Mia on depressive symptoms and subjective well-being in the perinatal phase. So do feel free to check out Mamma Mia. Just search for it in App Store or Google Play. When you register, say you're pregnant with an upcoming due date, so you get immediate access to all the sessions in pregnancy. You can then press I've given birth and then follow the program as intended from there. And make sure you don't register as a research participant. Thank you.
Okay. So we now have, I think, about 20 minutes for some questions, and we have a lot of questions. So I'm going to try to see if I can figure out Slido. So this is a question for Ástóra and Cecilia. What resources do midwives have for mothers experiencing anxiety and depression during pregnancy or after birth? Because we see that, as Thea was telling us about, we don't have Mamma Mia. So what do we have in Iceland?
Yes, we have, here is Tímir.
We have national guidelines, both in prenatal care and well child care. And then we have, these are the guidelines for well child care, and they're very specific what to do. For example, if the mother, how she scores both on the PTS scale and also the general anxiety, GAD-7 scale. And then we can refer women in need to psychologists in the healthcare centers during pregnancy and in the first 2 years after birth, and they are a priority group for the service. So,
yeah, the resources we have is for the first, we invite the women to have more visits to us. They can visit us. Yeah, okay. They can get more visits to their midwife when they're pregnant, and they can. We have an offer that they can have on CBT course with us for every pregnant woman. We are having that, and if they are need more, then they can go to a psychiatrist. And of course, if something worse is going on, then we can refer them to the hospital. Mm-hmm. But we start with more interviews and the CBT treatment.
Mm-hmm.
Thank you. Eva, I have a question for you. How did you measure the benefits of the parental groups?
Yeah, sorry.
You have to read each of the studies that is in the guidelines from the Social Health and Welfare. They have one part of the report is about benefits or evidence of parental supporting groups, and you can also read recently the book from 2021 from Karin Frislund, Anita Berlin, and Mia Barimani about research. It's about research and connecting to parental support groups during antenatal care and child health care, and there you have all the facts you need.
Okay, thank you. And I find this so interesting because I think we lack this in Iceland. There's another question about the groups. Do the healthcare providers who run the parent support groups in Sweden, do they have specific education in accordance with the project? You mentioned that it's run by midwives, yes? And do they have any specific, do any other healthcare educators run the groups, or is it just midwives and they get special education on it, or how does it work?
It depends on the regions. The regions in Sweden are quite independent, so they decide on that within their own child health care or antenatal care. So it depends on what's going on there, but there should be, because the normal education as a nurse and a midwife is not that much included, so they need this extra training, I think.
Yeah, so it's extra training for the groups.
Yeah.
Okay, thank you.
Mm-hmm.
Thea, I have a question for you. Or two questions. Who finances Mamma Mia? And then the second question is the therapy in Mamma Mia interactive? Is it a guided self-help program? Is there any therapist input? Can you explain a little bit more about that?
Yeah, so can you hear me properly now?
Yes.
Okay, great. So it's financed by the Research Council of Norway. Yeah, and also a smaller part by Arbip as well.
Okay.
And can you repeat the second part of the question, please?
Yes. Is the therapy in Mamma Mia, is it interactive? Is it a guided self-help program, or is there any input from a therapist or something like that?
Yeah, so in and of itself, Mamma Mia is a self-help program, so there's no interaction with a therapist. So it's not guided, but it's tailored. So based on how you respond on the Edinburgh Postnatal Depression Scale, in the program you get a differently tailored material.
Okay, thank you. I have another question for Astora and Cecilia. There were several questions about those mothers who do not receive the home visits. So the 20% not receiving home visits, what group is it? Specific parts of the country and so on. And also some questions about mothers that have to stay longer than the 72 hours in the hospital, who may have some difficulties. What happens with them?
Yes, of course. We have talked about it for many times that we would like to visit the women that are having difficulties and have to stay in the hospital for more than 3 days. But as it is for now, the contract only lets until they are usually staying longer in the hospital, so the contract doesn't work for them, sorry to say. But what group it is mostly, of course, women that have given premature babies and their babies are sick, and or they are sick themselves. So that's mostly the part of the women that can't go and get the service.
Thank you. There are several questions here. So, is it good enough to only screen for postpartum depression and anxiety soon after birth, or should it be done also at 3 months, 6 months, 9 months? And I'd be curious to hear from you as well, from Norway and Sweden. When do you think we should be screening for depression and anxiety? At what time?
When we developed these national standardized guidelines, we use the NICE guidelines, so we're working according to them, and so we ask these 2 questions that I talked about during the first home visit, and then if necessary, then we administer the EPDS and GAT7 in full. But then all mothers are screened at 9 weeks, at the 9-week appointment, and then again we 3 months, 5 months, 12 months if necessary. So we assess each case, each mother, and if needed, then we screen them. But routinely, we only do it at the home visit and the 9-week visit in well child care.
Yeah, I might add, we do it in maternity care, we do it in 16 weeks, and as often as we think is necessary. We do it more often if it's needed. And I would like to add as well, we started only last November, then we started to invite all parents, new parents, to come and visit us and talk about the birth, delivery, and the feelings, emotions about that. So we are giving every parents a chance to talk about their feelings, and if there was something wrong or they wanted to know better and so on.
I would like to add also, all spouses or partners are screened if necessary. We don't screen every spouse. Some health centers do in the country, but usually, and in general, we don't. So we screen all mothers, but if there's a need, then we screen the fathers or the partners also.
That's the same in the maternity clinic.
Yes, this was another question. Why don't we screen the dads? How is it in Sweden, Eva? Do we screen the dads for depression?
Pardon?
Do you screen the partner of the mother for depression?
We screen the pregnant woman with EPDS, and there should be a special parental talk with the other non-pregnant parent, and not kind of screening, but these woolly questions, if you know about them. Yeah.
Yeah. Thea, can dads or partners of pregnant women, can they use Mamma Mia?
So Mamma Mia is developed for the mother, and when they first developed the program, they also spoke to dads about their experiences and needs from this kind of prevention program. And they didn't really want something that looked like Mamma Mia. They wanted something that was more of a search base and not tailored and following them through the pregnancy and postnatal period. So therefore, Mamma Mia wasn't developed for fathers, but there is the parent room where a lot of where they're encouraged to share the psychoeducation and also exercises and assignments that they can do together with their partner. So yeah, hopefully, or we hope that will bring them into the dialogue somewhat, yeah.
Yeah. Are there any specific guidelines? This is an interesting question. Are there any specific guidelines for health professionals to use when screening for depression with parents that are not neurotypical? So parents on the autism spectrum or ADHD. I've actually never heard anything about this, so I'm interested to hear if anyone. Thea, do you have any comments on this? Parents who are not neurotypical, so parents on the autism spectrum, parents who have maybe, or for that matter, some difficulties in general, learning difficulties, ADHD, some challenge, which definitely has some challenges when it comes to parenting. Is there any support or any way to support those parents? Do we have any guidelines for that? I don't think so. Maybe that's something we could do better with, definitely.
We don't have any guidelines, but we ask these people, of course, us, any other, and we do it by some other way, but not any guidelines, just do as you think is best each time.
Yeah. What about screening for spousal abuse in the home visits or prenatally?
What?
Screening for spousal abuse.
Yeah.
Do you screen for spousal abuse?
Yeah.
Yes. When?
In all maternity care, we screen for spouse abuse or for abuse on the whole, and ask about if there have been any abuse ever, because we want to know, even though we're not in an abusive relationship now, as we know, the feelings can come up when they get pregnant, even though it's many years since they were in abusive relationship, so we ask everyone.
Mm-hmm. Okay.
And of course, when they are alone.
Yeah, thank you. Okay, so now a question on sleep. I think this is a hot topic for many parents. So this is actually a question for all of you. So for the home visitors, are they talking with parents about developing healthy and safe sleep for the infants? Is sleep something that is a focus in the groups? And is sleep something that you can get advice on in Mamma Mia? So it's a question for all of you. Eva, what do you say? Is sleep a focus in the parental support groups?
Sleeping habits of the whole family, or especially for the parents or the children, or what?
It was about developing healthy and safe sleep for the infants. How parents.
Yes, of course. All the habits during the first days and years are on the question, on the board of questions. So, of course, yeah.
That's one of the main topics in well child care. There's a lot of discussion and about sleep. And during the home visit in well child care.
That's one of the most popular questions in the home visits. So we talk a lot about it, yes. And we emphasize, it's good to know, we are trying to emphasize always more and more about for the parents to keep themselves healthy, to rest a lot and try to exercise and go out and everything like that, because we know that if I'm feeling well, then I'm good with the baby.
Thea, what does Mamma Mia tell us about sleep?
Yeah, so there is information, psychoeducation about the baby's sleep and the mother's sleep as well inside the program, and it kind of follows where she is, so through pregnancy and after birth. And also this is a subject in the early in program in the Well Baby clinics, which will be presented in a later session, the next parallel session.
Okay. Thank you. And while I have you here, Thea, there's a question about privacy. How is the data stored? Is privacy guaranteed? I think this is an issue of security that maybe worries some people, some users.
Yeah, so after the Norwegian Directorate of Health licensed the program, the data protection got even stricter than it already was. So it's in that version of the app, it's completely anonymous. While in the version that we use in the research, we have to be able to identify who is using the program with the data that we collect for research purposes. But obviously, this is all within what the participants have consented to and stored very safely.
Okay, thank you for reassuring us. Eva, I have a question for you. Should offers for support, should they come from other sources as well? Community centers, daycare centers, or not only healthcare systems?
I think it's very good if you could collaborate with the civil sector. There are a lot of good initiatives, non-profit ones, and we have these open preschools in Sweden, and some of them are from the municipalities and some are within the churches. So I think that's a very good idea to collaborate with.
Yeah. And while you have the microphone, I'm going to have another question for you. How much, because midwives, I think all over the world are super busy and they have a lot of things on their hands. How much time should be spent leading these these parental groups? Do they organize the groups, or is there support staff to organize the groups?
Yes, they organize the groups themselves, and have the number up to 10% of their time. It might differ, and it depends also on how they collaborate with the child health nurse, with open preschool teachers, and so on. So,
okay, thank you. Okay, I'm trying to ask as many questions as I can. We have about 5 minutes left. Okay, so Austra and Cecilia again. There's questions about guidelines. Are there any guidelines on how to assess the needs for home visits after 6 weeks? That's a question. And another one, what about screening for traumatic or negative birth experience? Do we have any guidelines about that?
We have home visits the first 6 weeks. So when the child is 6 weeks old, then the parents come to the health clinic with the child. We used to have a home visit at 9 weeks when the infant was 9 weeks old, but now the parents come to the health center, and just it saves time, and there's shortage of nursing and so forth. So no, we don't have any. So after 6 weeks, then all the visits are at the healthcare center.
We have no screening for traumatic birth or negative birth experience yet, but we are working on it. But as I said before, we are inviting all women that they can make an appointment with their midwives to talk about their birth and their feelings about their birth. After we recommend around 6 weeks, but they can make an appointment with us whenever they choose to. But of course, it's very often good to let a little time go by before they start to talk about it. So that's what we are doing now, but we are working on
some screening, hopefully next year.
Thank you. Thea, I have some more questions about Mamma Mia. So there's a question about why does Mamma Mia not mention anything about breastfeeding? There's a question about the link between breastfeeding expectations and postpartum depression. Does Mamma Mia mention something about, is there something about breastfeeding in Mamma Mia, or is that not addressed there at all?
No, I think it is addressed, but maybe not to a huge extent. And I think that's also because, I mean, there is psychoeducation about the importance of it, but we don't want to put more pressure on mothers around this issue. And it's also covered very well at the Wellbeing clinics. But there is definitely information about what to expect, and also about kind of managing these expectations in terms of kind of the self-efficacy perspective.
Yeah. Some people are already trying it out, and it says not available in your country. Is there any way for us to try it, Mamma Mia, if we're not in Norway?
That's interesting, because it should be available if your phone is set to, maybe if the phone is set to Icelandic. That's actually very, that's a good feedback. I'll definitely take that to Change Tech and see if there are any limitations on that. So please do email me, and I'll try to see if there's any way to get around that. But it's available in Norwegian and in English as well.
Okay,
for the moment.
And my final question to all of you, and this is an interesting question. Which method is better to get better parental equality in childcare and upbringing? Is it through sort of laws and rules, through force, or is it through flexibility and education? So it's always this difficult question. Do we make a rule and laws, what has to happen to everyone, or what about, or is a flexible way better? What is your opinion?
Yeah, it's a big question. No, I believe flexibility is better, because you have to, of course, the rules, laws and rules, of course, they matter, but flexibility, so you service the family as they need, so as needed. So that's my question, my answer.
Yeah. I would say the rules are necessary just to keep in mind and just to make sure that you aren't forgetting anything. But flexibility is the most important thing, to meet the parents on their ground and see what they want to do.
It's a very difficult issue, and I think a combination is the best, but my private opinion is that, for instance, the insurance we have in Sweden, I think you could share it equal for the parents. All other insurance we have in Sweden are individual, except for the insurance during parental leave. So,
thank you. Thea, do you have a comment?
I agree that a combination is probably necessary, and I suppose Mamma Mia in combination with treatment as usual from Wellbeing clinics does offer exactly that.
Okay. Well, I think this is all we have time for. Thank you very much to all of our speakers. We now have a break, and the next workshop starts at 2:30. So give it up for our... Thank you so much.